Good afternoon and welcome to the Auburn Medical Group YouTube show. We have Dr. Mark Vaughan and Megan Mobley.
Excellent. Yes.
We've got someone.
And we're glad to have us. Thank you. Thank you. Faceless announcer off in the distance somewhere. Yeah, and welcome to the Auburn Medical Group program. As Ed said, we are glad to have you, and we do have Megan Mobley filling in for the taller Dr. Gawain, who would normally be sitting here. Again, we are following the recommendations by the CDC, the interim recommendations for people with full vaccination, because we are fully vaccinated. We are maskless in this facility here. Let me take care of the noise. We're not supposed to hear that. And we do know that a lot of people have been joining us already. Deborah Ronker already did a super chat. That's great. Thank you, Deborah. And also Lindsay Antoine gave her greetings. Ed, anybody else either chiming in with comments or questions this early in the program?
We have Lindsay Antoine.
Lindsay Antoine.
And she wants to know,
what is it?
How do I read this thing?
Technology is a challenge.
What does she want to know? She just says, hi, guys.
I know, she just says hi. But
Okay, that's fine.
we're talking about women's health today, but no question.
Yeah, that's okay. They'll get to it. Yeah. Oh, yeah. Help there. Women's health. You know a little bit about women's health.
Just a little.
Okay. So, and I brushed up a little bit because of the whole women's health initiative back in 2002 and so I won't give it all away just yet. But we will be touching on that.
Absolutely.
And yes, I found that I'm not alone in needing to get a refresher on that, because the field's been changing for lots of doctors, and there's actually been studies that have been showing that doctors coming out of medical school and residency feel ill-prepared for addressing menopausal issues. Which menopause is not the only women's health issue. It's just, I know the demographic of our audience, and so I'm trying to cater it to a lot of people who are watching this right now. And Ed, you go ahead and just interrupt us and chime in whenever somebody is saying something to the show or to us.
Okay, I'll do that.
Okay.
You go ahead and proceed.
Okay.
And I will, I'll let you know when.
Okay. Is that because they're having a conversation amongst themselves, or?
It looks like it.
It's not because of terribly inappropriate comments or anything like that.
Nothing.
Okay.
You want to hear the inappropriate?
No. Maybe not over the air, but the good ones.
All right. Okay. I'll let you know.
No, we prefer not to have that. So should we jump into it?
Why not?
Did you want to cover early women's health?
Sure, we can start from the beginning.
Okay.
Absolutely.
Okay.
Absolutely. So, women's health really starts at a young age, learning about body and what to expect with puberty and development and menstruation. And so that's huge, and that can come from your pediatrician or your family medicine doctor, nurse practitioner. And so really just kind of talking to the young girl and explaining all of that. And then we get into official recommendations from the American Academy of Family Physicians, from ACOG, the American College of Gynecologists, and their recommendation is we start with cervical cancer screening, pap smears at age 21. So that's kind of the next step and where we go from there. Where do you want to go from there, Dr. Mark?
Yeah, that would be somebody who is not in the process of being an obstetrics patient. We would call that gynecology before pregnancy. Mm-hmm. And yeah, you already covered it, that one of the earliest, what's the word for it, care gaps or recommended health screenings we have is cervical cancer for women. That is the one that we actually do annually. You said from age 21 to age
65.
No, the I'm sorry,
not cervical cancer screening.
Chlamydia.
Oh, chlamydia screening. So we start that at age 15, and we go until age 25 on an annual basis routinely. And so we do that through urine, and that we also can do at any point in the lifespan if there's concern for those infections as well.
Yeah.
We have a question.
Yeah,
yes.
Go ahead.
Lindsay Antoine. Her question is, what is the average age for perimenopause to begin?
Okay.
Sure.
We'll get to that.
We'll get to that.
That's a good question. Lindsay, we will answer that question, just not right now. So as far as the chlamydia screening, you said age 20 or 15 to age
24, 25.
And why do we stop?
That's a really good question. I am not sure, to be honest with
There
you.
is a reason that it has to do with the statistics. It has to
makes
do
sense.
with who is the most likely to be catching chlamydia. And so that's why we don't automatically get it after that age. What we do is we ask questions and to find out if a patient is at risk, if they're having multiple sexual partners, if they are, well, that's pretty much it. New sexual partner since the last time they got tested is pretty much the reason for doing it.
And especially important as we see a surge in antibiotic resistance among chlamydia.
Not only
And
antibiotic
gonorrhea.
resistance, a surge in chlamydia right now during the pandemic. For some reason, it's all over the place. And although, are we seeing it in our office?
I don't believe so.
Okay. But in California, it has really gone up since the pandemic started.
It's true.
With not paying attention to it. And I guess because...
Not social distancing.
Thank you. That... Not the social distancing. That's what causes chlamydia to be passive. So, but in addition to screening for chlamydia, another somewhat early screening that occurs is cervical cancer. And we're testing in that case for the HPV, or human papillomavirus, which we should actually back up and talk about that later. But
Yes. So we start with PAP only at 21, and then we include high-risk HPV strains with the PAP smear starting at age 30. And the reason for that is because prior to age 30, if a female gets an infection with HPV, especially those high-risk strains, they're often able to clear it from their body, and it's not a risk. So it actually can lead to more false positives and biopsies and concerns if we screen for HPV too early.
so you can actually over-diagnose HPV, catch it too early, strangely enough, because you don't need to do anything to it if the body just takes care of it and makes it go away. You cause more harm than benefit. But as it stays on beyond age 30, then we're starting to have risk for cervical cancer if it's sticking around, and that's why we're doing the screenings currently with both the HPV test and with a PAP, although that may change. I don't know, have you been reading about the possible changes coming up in recommendations for that?
Just early.
Yeah, we're not there yet, but we're looking forward to a future of maybe not having the PAP portion, but they would still have to go through pretty much the same experience at an exam.
Possibly. There's even some early studies that I've read about self-testing with just a vaginal swab.
Wow, do it yourself.
So exactly. Now then you
Okay.
of course lose the pelvic exam, which that's sort of another area of debate as to, how much good that provides.
Yeah, how much information are we really losing if we don't do that?
Exactly. But a big area of research, which is exciting.
Yeah. Okay. Yeah, and we don't want them to accidentally do these home testing for cervical cancer by sticking in their nose like the COVID test. We want them to be clear
not.
on which orifice
Yeah.
the swab is stuck in.
Yeah, your cervix is not in your nose.
No, we'll go we'll go over that when the time comes for home testing.
Absolutely.
Were you reading some questions there, Mr. Ed?
Well, I don't know that they quite relate to what you're
That's okay.
talking about.
That's okay. It's their show too.
Okay, do you want the question?
Some of them are paying for it, so into the mic preferably.
All right. Okay. Now, next question from Connie Besessi.
Yes.
Can we choose what vaccine we can get?
Oh, okay. So this is a COVID question. I'm hoping maybe it's the HPV vaccine. I don't know, but
Oh.
we could cover both. But yes, there's an HPV vaccine, and there are different ones. The 9-strain valent, isn't that it? The nonavalent now that we're giving to both men and women before the age of sexual activity. That's how you keep them from spreading and getting this HPV that leads to cervical cancer in women and can lead to some certain types of cancer in men too. That's why we're getting both sides. Well, we're getting both sides because anybody can get cancer from it, but we do encourage people to get those. We want you to get the 9-valent, the one that covers the 9 strains. Now, a question about, this was I forgot the first name. Bissay?
Connie Bissessi.
Connie. So Connie asked, can we choose which vaccine? I think Connie is probably talking about the COVID vaccine. This choosing which one. What do you think about that?
Well, I think any vaccine is the best vaccine as long as you can get one.
Yeah, best vaccine's the one in your arm.
Yeah.
If you were to have a choice, or if you were to go to a facility that had both to choose from, I see no reason not to let somebody have their choice.
Sure.
If we had more than one, which we don't even have any now, but if we had more than one, yeah, I could see saying sure, because they're very similar in what they do. We don't really have a significant difference as far. There may be little differences as far as age groups and efficacy, but yeah, it's just not that big enough a deal to really want somebody to get one over another. So yeah, I would certainly, if I was in charge of it, let somebody go ahead and pick of the ones we have available.
Sure, why not?
Yeah.
And,
Mr. Ed, what do you have there?
Well, Debbie Ronker has a statement here. I received my vaccine 2 weeks ago.
Good, Deborah.
Is that Deborah? Okay. She says, I received my vaccine 2 weeks ago. I only had a very stiff arm.
A stiff arm.
Yeah.
Mr. Ed, do you want to share your experience?
It's a bad joke.
Oh.
I didn't feel anything either. But after that second shot of mine, I fell in love with Nancy Pelosi. Sorry, folks.
And I'm sorry to admit, I actually don't get it. Okay.
I thought you were going to say Dr. Fauci, but...
Either way.
Other people will say that. What's that big orange thing there that we just saw on the screen?
Well, now that is a statement from Laura Barzik.
Oh, Laura.
Laura. Sounds like somebody you know already.
How much was it?
$19.99. $19.99.
Okay. Laura, thank you. I believe Laura's from Minnesota, if I'm not mistaken. No.
Doesn't tell me here.
I think she might. She'll probably tell us.
She does have a question for you.
Okay, what's Laura's question?
At what age and how often is it advisable to get a bone density scan for women?
Oh,
good question.
Oh, does that mean you want me to take it?
No, I can take it.
Okay, go ahead.
Yeah, so we typically start that at age 65. We do an initial screen of bone density. That's done through a DEXA scan. And we really just need the one-time screen. Now, there may be findings to follow up if we find osteoporosis or its precursor, osteopenia. Some clinicians will have certain intervals to follow that up, especially based on what therapies are started. But the short answer is age 65.
Yeah, and then if we do start treatment, like you said, there'd be an interval to recheck it. Mm-hmm. Also, because the treatment is often recommended to be done with a vacation, meaning you take it for 3 to 5 years. I think it's more toward the 5 years. They recommend taking it before stopping.
The holiday, yes.
The holiday, okay, I call it vacation, which I believe is for the same period of time that you're off of the treatment.
I believe so.
And then maybe going back on. Okay. That was a good question. Thank you. And thank you for the super chat. We appreciate that.
Here's another one. Deborah again. Deborah Rocker. I had cervical cancer, but they didn't get it until I had a cesarean section.
Oh, okay. Cesarean. Okay. So they found it on the cesarean? Or after?
Or they did a PAP during the cesarean?
That doesn't sound like...
It doesn't sound...
a reverse PAP?
Very strange. I don't know.
While they're open, the abdominal cavities and pelvis, you swab backwards through the...
Since I don't do cesareans,
I don't know.
I can't imagine, but...
I'm glad it was discovered, though.
Let's move ahead.
Yeah, let's do.
Deborah, Connie comes back.
Okay,
Connie Bissessi comes back and says, yes, I am.
From Minnesota.
Okay.
Oh, wait.
Maybe.
No, it was Deborah I was saying was from...
Connie,
I don't know.
We don't know.
We don't know.
Sure.
But Deborah is. Whatever the question was, Deborah is. Thank you.
And then Laura comes back with
Connie,
Chicago. So we didn't know where Laura was from either, for sure.
Laura's from Chicago.
Chicago.
Laura's from Chicago, and Suki M, if you're there, is from Minnesota, Wisconsin, Minnesota.
And then Willie Weicker comes in and says, why is my poo regularly solid with blood?
That should be checked. I'd like you to see a doctor about that. Let's move on.
Okay, Deborah. Laura Barzik again. Thanks. I had a scan around 40 and was diagnosed with osteopenia
At 40.
but was never told to follow up.
Yeah, it'd be time to check again. Well, actually, I don't know how old you are, but if you're 65, because we would not necessarily do we would intervene for osteopenia. What would we do for just osteopenia, not osteoporosis?
Sure. Well, we would do weight-bearing exercise. We would recommend calcium and vitamin D, avoidance of alcohol in excess, smoking cessation. Those would all be great ways to improve your bone density.
Which we recommend most of that anyway. But yes, certainly that would be another reason to stop smoking, to get weight-bearing exercise, to not be drinking in excess. So we left off with young adulthood. We were just crossing over into OB, which I don't know that we would necessarily, in this setting, in this discussion, cover a lot of OB when we're talking about women's health. And the reason is because that would be covered by an obstetrician much better than us. And we kind of, in our practice, hand the patient off temporarily to cover those things with our obstetrician while we're still available for any other medical needs. Are you comfortable with handling it that way?
And I would just add making sure that they're taking their prenatal vitamin.
Yes. Early and continuing.
And Laura Barzak says she's almost 60.
Okay. So she's coming up.
Probably time.
Yeah, coming up on time to get checked. And there's other reasons to get it checked early, like if you've had a broken bone. Is that about it?
Perhaps early menopause in some cases.
Okay.
If you had a hysterectomy at a very young age.
Okay. So,
there are always exceptions.
Was she the one who's...
At 40. So it's been 20 years. It's probably time to repeat the DEXA scan.
Have that conversation with your doctor at least. At least bring it up and talk to them about it. So then women's health is a lot of the same, interrupted by some visits with or management by an obstetrician if they're having children during the childbearing years, until they get to the age to start screening for breast cancer, which has undergone a lot of changes in the last 2 decades. So what are we doing now?
Well, it depends on which guideline we're following. Now, in family medicine, we tend to follow AAFP, or the American Academy of Family Physicians. And so based off of that recommendation, it would be starting at age 50 and proceeding every 2 years from there. Of course, everything has exceptions. If you have a family or personal history of breast cancer, if you've had, lots of hormone therapy, there's always possibly exceptions to discuss, but that's generally what you'll see us doing in family medicine.
So yeah, family history would be a reason to go a little bit earlier. Of course, personal history of breast cancer or having something that had to be removed. Why is it that now we're waiting all the way until age 50 to start screening? Because it was age 40 at one point, and doing it every other year instead of every year. Why?
Good question. It's because we're continually looking at the guidelines and the evidence, and we're continually asking, what is our harm versus our benefit? And so what we find is that by starting breast cancer screening too early, unless there's those specific indications, we can tend to overdiagnose. We can tend to cause unnecessary biopsies. We can tend to cause more harm than good, similar to testing for HPV too early.
Yeah.
And when we look at the difference between every 1 year and every 2 year breast cancer screening for the general population, doing mammograms every 1 year versus 2 is really not related to any decrease in mortality from breast cancer. So we really don't make a huge impact when we look at those end goals of those studies.
Not making a difference in
mortality, but prolonged life.
But possibly making a difference in biopsies that maybe didn't need to be done as often, if you're only looking every other year instead of every year. And there's a lot of women walking around who have had surgical procedures done, and it didn't turn out to be cancer. And that can be bad. You do enough of that and somebody's going to get hurt. And it's being done on a big scale. They are doing enough of that people get hurt, besides just the inconvenience and the trauma of concern for possibly having breast cancer and going through the surgery. There are, a certain number of people who will, in a given procedure, have bad outcomes or complications, or rarely, but sometimes even death. So decreasing that without sacrificing the mortality benefit of doing the mammograms, the recommendation came out to do it every 2 years by some bodies. Not the radiologist, though. They'll actually send you a letter and they say, you need to get your primary care doctor to write an order for your mammogram every year. Funny, it's only the radiologists, and they're the only ones who get paid for the mammograms. Just something to think about there. Okay, Mr. Ed.
Lindsay has a question. Lindsay
All right,
Antoine
Lindsay.
again. I was diagnosed with HPV over a decade ago. It's caused several abnormal PAPs since, and my body won't permanently clear it. I get a PAP every year.
Yeah, it's usually younger women who are able to clear, not too much younger than you, but a little bit younger. And yeah, all you can do is keep rechecking.
It's true. There are different guidelines at play when we're talking about people who have had an abnormal PAP, and a lot of times that's managed through the gynecologist, because they're the ones who typically will do the colposcopies or other procedures to look more closely into those abnormal results.
Yeah, we hand that off to the gynecologist and go by the guidelines. Who is it that does those guidelines? It's actually pathologists who do the guidelines for what you do for the abnormal PAPs. And they've got this table that we always refer to from a few years back for what to do according to if the PAP was normal but it was a positive HPV, or the HPV was normal but they had some abnormal cells but they don't look cancerous. All different recommendations that I always have to look it up every time to see what it is for an individual patient. Do you have something there, Mr. Ed?
Deborah Ronker. She says the doctor said during the pelvic is when they found it.
Oh, okay. Actually, it sounds like when they did the procedure, the C-section that she had, they discovered something abnormal with the cervix while they would have done the pelvic, because they do a regular pelvic exam when you're going in for a C-section. Well, I'm glad they found it. That's great that you didn't have to suffer from it more than whatever it took to treat that. Was there another one there, Mr. Ed?
Nothing new. I'm kind of waiting here for the next one.
Wait. Oh, what's that big green thing?
Well, that's from Lindsay Antoine.
How much is that?
$5.
Lindsay, thank you.
$5.
Look, that's not great. That's pretty good. Okay. So we got to
Breast cancer screening.
breast cancer screening, which starts at age 50. So now we're going to what else happens
DEXA
what else happens in women at age 50 usually, or around there?
Well, menopause.
Yeah, that's a big part of women's health, is anticipating and working through menopause, typically happening at age 50, although not always. It's kind of got a 10-year span there of like 45 to 55, and usually is preceded by even up to a year of irregularity of periods. I'm not having them anymore. Oh, surprise! 2 months later, I have one. I usually have them every month. It can be unpleasant to go through, and then it's not really done until you've gone a year without any periods, and then you have the symptoms of the vasomotor spasm, the hot flashes. You can have some mood changes with it also.
Trouble sleeping.
And also what they call the genitourinary symptoms, like painful intercourse, dryness of the mucosa or the lining of the vagina, which can be very disconcerting to patients. And so then the old days, when I say old days, I mean as I was being trained in medicine, the treatment would be to give everybody hormone replacement therapy. Then the Women's Health Initiative was published in 2002, which was a decades-long study of many women. I think they were probably in Framingham, Massachusetts, like all those Framingham studies at Harvard. And they found that it's not necessarily, or was Women's Health Initiative the one that was all nurses? And either way, it was probably over there. And then they found that, well, it actually looks like the women who got the hormone replacement therapy have a higher incidence of certain problems, including breast cancer, uterine cancer, and heart disease. Was that correct? It was all three of those, which was attributed to the hormones that they were using for the replacement. And there's kind of a tricky thing there. You're supposed to add progesterone because of risk of endometrial cancer in women who still have a uterus if you're going to give them the estrogen. Whereas the women who don't have a uterus, they've had a hysterectomy sometime before they go into menopause or after, they don't need the progesterone, they just get the estrogen. Are you hearing anything I need to...
Andrea from Adelaide, Australia.
She came, AAA.
Once again, she says, first of all, she says, you'll never forget where I'm from, because she's going to spell Adelaide, Australia in her note here. And then her question is, I'm post-menopause. I'm not on any hormone. Is that a good thing or bad?
Oh, now that's what we need to talk about. So in 2002, the Women's Health Initiative came out, and everybody, when it first came out, thought that hormone replacement was bad. Well, I shouldn't say everyone, but there was a very big backlash against the use of hormone replacement therapy following menopause or to treat menopausal symptoms in the early 2000s. You want me to keep going?
Sure, keep going.
Did you have anything to add?
No.
Okay. So now it looks like, as you look at when the hormones are given and who they're given to, there might be actually a group that benefits from it without having this risk. And it looks like if you give the hormones early, like right after menopause or right during menopause, and do it for, say, 5 years, and then reassess, do we really need to be doing this? That you might be able to get a lot of benefit for addressing those symptoms we described earlier without the cancer risk increasing. And afterwards, even some people suggest even making it specific to the patient, having a conversation with them saying, there are these risks for these cancers and for heart disease with continuing to use these medicines. How bad are the symptoms? How much benefit do you get in day-to-day life, in your quality of life, with continuing these medicines versus if we were to taper you off of them? Yeah,
Sure.
That's kind of where you're at with that too.
Absolutely.
Okay.
I think that a lot of guidelines, and we see this not only in women's health, but a lot of guidelines are going to shared decision making. So really looking at all the body of literature with your provider and letting them inform you on what that is and making a decision together on what is right for you in your specific symptoms, in your specific body, etc. So I think that's what we see here as well. And I will also note that there are some great, more targeted estrogen therapies specifically for those genitourinary symptoms of menopause. So those can be something that, since they're more local, can be done with a little less risk for a little longer time, all depending, again, on what the specific symptoms are and what that shared decision making is at the end of the day.
Very good. And I don't think any discussion of this would be complete without bringing up the bioidenticals. So bioidenticals, unfortunately, it actually can mean different things. Popularly, it's become referring to some kind of a compounding pharmacist mixing different things together in a way that's not approved by the FDA. It hasn't been cleared, hasn't been tested. And sometimes it implies that the physician that's prescribing it is checking hormone levels and adjusting according to that, getting just the right balance, supposedly. And by the literature of the standard groups like the ACOG, American College of Obstetrics and Gynecology, AAFP, the places that we go to for, hey, how do we interpret this data, from the doctors that we respect who are leaders in medicine. And their conclusion is, looking at the studies, you don't get benefit from doing these things, and there may be harm. I don't know that there's actually any proven harm to it, although sometimes they'll use levels that haven't been FDA approved when you're given it through the regular pill forms. But there is concern there. And again, no better results in the blinded studies compared to, if there's even been much study, compared to just the regular way of giving the pill or the patch. or the cream. For example, treating the vaginal symptoms with a cream. Okay, Mr. Ed, what do we have out there?
Connie comes back with, I heard that some women go through hot flashes through the rest of their lives. Is that true?
Yes. Yeah, we need to talk about that. So that's where that individual decision making comes in. Is it worth taking some risk for the cancer and the heart disease? And so we look at things. We look at, do you have a family history or a personal history of breast cancer or endometrial cancer? Do you have a problem with migraine headaches? That's another reason to not do it. Are you at risk for having a blood clot? Do you have one of those known blood disorders where you are at higher risk for having a blood clot, so that you shouldn't be taking these medicines? And those people, if they're continuing to have the hot flashes, you're going to work more with like an antidepressant, an SSRI, like the Prozac class of antidepressants, to try to help with the symptoms, rather than putting the risk of putting hormones in their body.
And those may be a great option for someone who wants to avoid hormones, because we can use those antidepressants or even other nerve modulating medicines like gabapentin to help with those symptoms of menopause in a safer way. Of course, no medicine is without risks. There's always that discussion to have about, what is the benefit versus the harm here. But there's, to my knowledge, no risk for cancer that's been discovered among SSRIs or gabapentin. So,
right, yeah.
So that's a good thing.
We would much rather use those if they work. And a lot of times we will encourage patients to try those. And you notice in this whole thing, we've been talking about things coming and going and studies being done, and then other looking at the studies and seeing, that the younger menopausal patients are okay without the risk. My practice has changed dramatically because of new information coming out about menopause and the risk of the medicines and the treatments and the benefits, and looking at the patient better with this shared decision making. Mr. Ed, do you have something there that's of great interest?
Well, Laura comes back with a statement saying that my mother had hot flashes for over 20 years.
Yeah, and that's miserable when people have
menopausal,
that.
yeah.
Most people, it gets better within a few years, and you're able to back off of the medicine. And a lot of them will still have some as you go off the medicine. And there's been studies that look to see if tapering makes it better. And it just seems to kind of make it less severe while it's happening. But 6 months after, either stopping cold turkey or tapering for 3 months, there's no difference between the two groups.
Well, we're not getting many more comments or questions.
All right. Well, we certainly thank our audience and Mr. Ed for joining us. Thank you for your announcing. For those of you falling in love with the dulcet tones of Mr. Ed's voice.
I think it's a good idea to have Megan here with you when you're talking about women's problems. So,
okay.
You two guys, not you two guys.
You didn't want to be the co-host of this show?
No, that's fine.
Okay. So if you want to give an encouraging note to Mr. Ed, you can do that in the comments or on the chat. And also Megan, too, for that
I'll
matter.
take them.
You'll take them, too. And, of course, we want to thank some special people like Lindsay Antwine and Boo Boo Kitty, who are helping they contribute to my Patreon and my YouTube channel, both. And, of course, all the people are members of the channel and on Patreon. Thank you for doing that. Until next time.
I'm Megan Mobley.
I'm Dr. Mark Vaughan, and today, Mr. Ed.
And this has been the Auburn Medical Group YouTube show.